So, welcome to the hands-on component of the ITB iliotibial band syndrome. So now that we've gone through the definition, we understand some of the predisposing factors, we know the symptoms of ITB, we're understanding the anatomy of the area as well. It's an opportunity for us now to go through the assessment and then also some of the treatment sequences related to treating this often difficult lateral knee pain condition. So we need to understand that the first part of assessment for the iliotibial band will always start with assessment of the lower back and also clearing the hip for any restrictions. So the imperative part of this will obviously be taken up by assessing those dysfunctions that we'll see in terms of changes in running gait or changes in training habits and the like. Any of those that will change the biomechanical function of the hip and the lower back. In terms of understanding some of these, there will be structural restrictions and there may also be some lumbar spine structural restrictions. In that case, we probably refer to other practitioners that deal and obviously can correct those much more specifically than we can, but we're certainly going to focus more on the soft tissue dysfunction that we'll see in relation to this. So obviously there will always be a muscle imbalance in and around the hip and the pelvis when we're treating our ITB. Keep in mind that the ITB tension is always increased if there is inadequacy or overload to the gluteal muscles, as they are the hip stabilisers. They will create the tension through the ITB. So treatment to the ITB in terms of changing tension should always be directed as releasing tension away from the gluteal muscles. Keep in mind we also do need to direct some attention to the deep external rotators as well. So that takes up the component in terms of understanding the underpinning restrictions in treating the ITB. Welcome back. We've got the lovely Jenna with us this afternoon. So we're going to run through a couple of tests that are really important when we're looking at the ITB condition. The first one is going to be our modified Thomas test. So this test is designed to give us an idea of the length and flexibility of the hip flexors. Now why that is important is because it obviously, with the hip flexors being tight, it will restrict obviously hip extension. Not only that, it draws into the lumbar spine as well, where it can also set up other restrictions and the like. So once again, we were talking about imbalances around the hip and pelvis, and the hip flexors themselves are a very big and important muscle in relation to keeping stability through the front of the hip itself. So I'm just going to go through the demonstration of this with Jenna, and I'm going to explain as we go through and what we can basically look for. So the first thing for Jenna is that she's going to sit right on the edge of the table here. So she's going to sit right on those bones at the bottom of the bum, which are our ischial tuberosity. So she's going to pick up her right leg for us, and then she's just going to roll back onto the table, like so. We'll just give you a pillow under there, like so. So now that she's in this position, it's this leg that we're actually more concerned with, and the height of the leg itself. So what we're doing here is the hip flexor that runs from the lumbar spine down onto the left trochanter. With a tight hip flexor, what you will see is that the leg itself, or the thigh, will stick up above the parallel of the table. If it's essentially the rectus femoris muscle, okay, coming down through here, then what you'll see is more of a pointing of the actual foot itself. Okay, so that would give us the establishment that that rec fem is tight. All right, you can just relax there, fem. We also need to take into consideration that the person that's on the table might also have a hyperlordosis as well. If that's the case, we need to take that hyperlordosis out. So what I tend to do is take hold of the person's knee here on their hands, roll them over and just stick your hand underneath their lumbar spine, so into the small of their back, and then we just drag the hip up until we feel it flatten out underneath our hands, and then you can hold that there. So now what we do from here is, one, we can visually see whether or not it's tight, and the second part of this is actually pressing down on the knee itself and seeing if it actually feels tight. Is that tight, Jenna?
A little bit.
Okay, so they may feel tightness right through the front of the hip here, or they may feel it down in the leg as well. If we're thinking that the rec fem might be tight, what I tend to do, because there sometimes is unconscious residual muscle contraction here, you can just bring the foot in, okay, and just relax there, Jenna, and just let it flick out. And basically it'll find where its resting point is. So if it is really tight, then it will stick out that. If it's not, sometimes it's just the client with some residual tension through there. So obviously we're just pushing down, feeling where the first point of stretch is, down through here, looking at the range of movement. So obviously the idea is if we have an imaginary line out here, okay, so if it's being parallel, obviously that's going to be tight. If it drops below that parallel, which is great here for Jenna, so she's got great hip flexor range of movement, she's well below that. So depending on the athlete or depending on the person coming in, that will differ in terms of how much range of movement they may need. So if you've got a soccer player or a football player, you might find that they need that much flexibility through there because they're obviously having to run and kick, where other athletes, they probably may not need as much of that range of movement. But it is absolutely crucial. All right, so that's the Thomas test. We're doing the Obes test now. So this is also a very crucial and important part, obviously, for the ITB, because this is where we do assess the flexibility of not only the gluteal fascia, but also the ITB through here as well. So for obviously being ITB, this is a pretty important test. And it's also the basis of a treatment sequence that we can go from here as well. But I'll just quickly explain the test. Okay, a lot of people get this wrong. Top leg, okay, you pick up. The bottom leg you will bring up into hip flexion as much as they can. Now, what's really important is that the client, as you see if I bring Jenna up here into hip flexion, she starts to roll back, okay, off her greater trochanter. I don't want her to do that. I want her to roll forward and try and keep her body in line with her hip. Okay, the next part of that will be having this hip and this knee in line with each other. Okay, so the knee, hip, and the body is in line with each other. The second part of this is that we're going to have right angles here. And then what I'm going to get Jenna to do is I'm going to get her to gently just push down into my hand here, Jenna, just about 10% of your maximal power. And then relax, relax, relax. And then we're just going to get the knee to drop away, okay? So now what we're looking at is essentially how much range of movement we've got. So if we draw an imaginary line across from the hip itself, we're seeing how much drop we've got here. If your client's got more than 10 degrees here and drops away, then I would assume that they've got reasonable flexibility through that ITB and gluteal fascia. If it just stays put and doesn't drop and doesn't have much give or movement, then there's a fair chance that this fascia is tight. Okay, but you have to keep in mind, it is crucial that the hip and the knee are in line with each other. Now the other thing is too, the hip, the knee and the ankle all need to be at the same height when you take this test as well. Okay, so if you have any variation on that, if you have the ankle higher than the hip and the knee, then obviously you're not going to get an accurate result. Okay, so it's really important, the positioning of each one of these. Okay, and as you could imagine, as I've talked to you beforehand, we'll go through in the treatment sequence is all this fascia through here, which is basically just a large roundabout of fascia coming through. So we've got the ITB here. It's really important that you understand that if there is tightness onto the ITB itself, then it is all going to be coming from this gluteal fascia. So if you want to increase tension through ITB, it'll all come from here. So in order to release the tension through this ITB, absolutely imperative that we focus on this area here. Okay, so we're back to do the straight leg raise. Now the straight leg raise is obviously a hamstring flexibility test. Also important because it attaches onto the pelvis. So you'll notice as we go through all of these tests, all of these muscles have a bearing over the position of where the pelvis can sit. So obviously the hip flexor is more related to lumbar spine. It does attach onto the lesser trochanter, so it can restrict that hip extension. Obviously the ITB and gluteal fascia, really important because obviously that is where the tension will come through onto that tissue. Now we're going to look obviously at the hamstrings in terms of them being short or tight. Now if they're really short and tight, then they're going to draw the pelvis forward and back. Back and down. So obviously that's going to create different tensions onto our gluteal muscles. So as we know, the gluteal muscles are really important for that. We will then turn Jenna over and then we'll do the pro knee bend, and that will also introduce us to the length and flexibility of the quadriceps. So let's just start with these hamstrings and see how flexible they are. So how do you do it? First thing, pretty simple test. We lock out the knee, okay? Make sure the foot is pointed, and then literally what we're doing is that we're taking the leg up into what we call a straight leg, hence the reasons of what it's called. So what we're doing here is that we have the hamstrings attaching to the back of the pelvis here at the ischial tuberosity, coming down and attaching down into the leg itself. So as we come up, what we're looking for, Jenna, just tell me, wherever you start to feel a bit of a stretch. Okay. So I'm starting to feel a little bit of resistance at this point, which doesn't mean that's her end range, but we take that into consideration. So she's getting up and just starting to feel a bit of tension there. Is that about right? So what we've also got to be mindful of is what's happening with this leg as well, because we don't want the other leg coming up, okay? Because then once again, we're not getting an accurate idea of what the length is here. Now Jenna's pretty good because she's almost 90 degrees, which is pretty good. Obviously you may see your inflexible athletes coming in and just struggling to get to 70 degrees. So that would be a little bit more on the tight side, but not unusual. So looking at that flexibility, looking at 90 degrees, very good. Now, what's also important is that because we do any of these tests, we have to test both sides, because what we're looking for is inconsistency. So even though Jenna might have great 90 degrees on this side, she may struggle on the other side. So just for argument's sake, we do the other side. So bringing the leg up and just feeling it about there as well, okay? So maybe just slightly tighter, but nothing that's considerable. What we'd be looking for is dysfunctional would be something that would be at least 5 to 10 degrees difference from one side to the other. So you can imagine if you've got a short, tight hamstring on one side, it's obviously pulling the pelvis back and down. That will change the relationships of what happens here for our gluteal muscles. And as we know, our gluteal muscles, okay, if we lift one leg off the floor, our gluteals have to switch on to stabilise our hips. Now, if they don't do that, then that's an issue. And the issue may also be is that if we got that short, tight hamstring, that obviously loads back in through the deep external rotators, the sacrotuberous ligament as well. So it can also affect part of that flexibility as well. All right, now that we've done that, we're going to go into the pro knee bend. So Jenna, what we'll get you to do is if you can flip over onto your front for us. Be always sure to tell your athletes or your clients how to turn over and what to turn over to, because you're not going to ask your clients to turn into a prone position because they probably don't know what is prone. So turning over onto your front. So this is the pro knee bend. The reason I call it the prone knee bend is because you're literally in the prone position and you are bending the knee. And so it's not rocket science. It's good to see a lot of these tests make perfect sense. Okay, so we're looking at the quadricep muscles themselves, okay, coming down the front of the knee, the front of the thigh past over the knee. So what we're looking at is the flexibility of these. Now you can imagine if these muscles are tight, then they're drawing the pelvis forward and down, okay, as opposed to the hamstring, okay, which is doing the opposite. So if we've got quadriceps that are short and tight and they are pulling the pelvis forward and down, then obviously it also changes the length tension relationship onto the glutes as well. So both of these muscles are imperative in terms of working out the balance situation with them. Okay, pretty easy. So we're bringing the heel towards the buttock. Okay, so we're taking it down until we start to feel resistance. Jenna, you just tell me when you start to feel some tension. About there, and you're feeling that just down the lower part of the thigh? Yep, okay. So important that you ask your clients exactly where they feel it, because they could feel it in the lower half of their quadricep, the mid, or even the upper part. So most commonly it's the lower part. If your client is able to reach their their buttock without any stretch, then you may need to introduce some hip extension. Okay, so the way that you can do that, I'll demonstrate here. You may sometimes put a pillow underneath here. So I'll just take this pillow here, Jenna, and just pop your knee up. Okay, pop that down. So now that we've got the hip a little bit more in extension, okay, that's put a little bit more tension through that. So for your more flexible athletes and clients, that might be the case that you need. And then that increases the tension, and we're looking for, once again, the same sort of scenario. You're feeling a bit tightness there? So once again, are you feeling that down? No, she's feeling it more in the upper part. Okay, but not unusual because we've got a little bit of hip extension there. Terrific, great. Okay, so I just really quickly want to talk to you a little bit about leg length because in the future what we'll do is we're going to put some modules together related to the assessment of the lumbopelvic area, which will be essentially a prerequisite for the assessment of this area. And part of that will be looking at obviously the symmetry of the pelvis structurally, and that will also dictate what happens with our leg length. Now, obviously the leg length discussion, we're not necessarily looking at assessing structural leg length discrepancies. We're looking at obviously the functional leg length discrepancies, where essentially there will be an imbalance through the pelvis due to soft tissue tightness or weakness or whatever the case may be. So it is also a crucial part of the assessment process. However, is a big chunky piece of information that we're not necessarily going to go through today, but we will go through in the future. But I just want to very, very broadly, very quickly go over some of the dynamics that we need to do when we are looking at leg length, because it is important when we're looking at ITB. So for instance, if we did have Jenna coming in, she's a marathon athlete, what we'll find if we're having functional leg length discrepancies, the most common occurrence that you will see is that the potentially one half of the ilium may drop forward and down, which is classed as, very broadly an anterior rotation. Now, depending on your background and education, obviously if it's osteopathic, they have their terminologies for it. But the common structural dysfunction that we'll see is if someone has an anterior rotation of the ilium on one side. So obviously what will happen there is there will be soft tissue changes that will adapt to that. But in terms of the leg length, obviously it will change the leg length. And because we're having the hip anteriorly rotate and the joint is here, then essentially what it does is it draws the joint back, okay, and up slightly, which in turn then does shorten this leg, okay. Now what you'll see is we'll need to do a test to determine that. So this test is called the Wilson and Barstow. Obviously after Wilson and Barstow, we're bending the knees up and the ankles together. Now it doesn't necessarily have to be 90 degrees as long as we've bent them up. And we're going to make sure that the ankles are together and the knees are together, and we can visually come up and just quickly check to see if the knees are at the same height, which is good. So obviously if there was some different heights, there may be some structural leg length discrepancies, but that's not something that we're going to cover now. I mean, structural leg length discrepancies really probably need radiographic evidence to be 100% sure. So now we're going to get Jenna just to raise her buttock off the table for us, and she's going to hold that for us and back down. Terrific. And then we're going to just, from the ankles, just gently bring the legs down, and then we come over the top of the legs here and just placing our thumbs inside and at the very bottom of the medial malleolus and looking down directly over and seeing if there's any changes from one length to the other, from one side to the other. What we'd be looking for in terms of a difference would be something that is literally one thumb width or more, okay? If it's less than that and you're sitting there and determining it couldn't be, then it's probably not there. So we're looking for significant changes in terms of the difference from one side to the other. In correlation with that, what we'd also do is we'd come up to the ASIS as well, and we'd find the top of the ridge there. So use your eminence, if you like, over the top to find the top ridge, then come down to the lower ridge of it, and then coming over the top to see if there's any difference from one side to the other again. So what you should see with any leg length discrepancy would be that potentially for an anterior rotation, this ASIS would be lower on this side. You would also, that there'd be a short malleolus on this side as well, okay? And then that would give us an idea that there may be a structural restriction here on an anterior rotation. So obviously giving us a short leg on that side. All right. So just going to quickly go through some hip range of movement testing. The first thing we're going to go through is the hip range of movement, so the active stuff. So this is where we get our clients to go through these ranges of movement. So it's an opportunity to see what they're like functionally. We can add in a couple of other little functional tests. Now that you've got all the underpinning knowledge and understanding of the symptoms, obviously being more of a lateral knee pain condition, we may be able to reproduce some of their pain doing some of these tests. So with our clients, obviously we want to be standing in front of our clients and just direct them what we want them to do in terms of this range of movement testing. So I'm only going to do one side as opposed to two, but obviously in the clinic you're going to be doing both sides and assessing what their function's like. When you're doing these ranges of movement, you're going to be looking at your clients and seeing what's happening with their hips as well, because as soon as you take your weight off one side, obviously the ability for your gluteals to switch on and then stabilise will determine whether or not they have much much sway or stability, or whether or not they're going to give through on their knee and so forth as well as looking at the range of movement of their hip. So the first one we're going to go through is flexion. So obviously the ability just to bring the knee up towards them, okay? Now they're going to be guided by essentially what they're wearing as well, but what we're looking for is one, range of movement, and also whether or not they've got any pain in terms of doing this, or tightness. The second part will be extension, so their ability to bring their hip into extension and their knee past their buttock. Then we're going to go into external rotation, internal rotation as well, and then abduction, okay, so bringing the leg out. We're going to do that both sides. Now we're going to move over and we're going to demonstrate that on Jenna with passive range of movement. Right, so now we're going to go through the passive range of movement, which gives us an opportunity to assess not only just any joint pathologies, but the end of range will also determine what's happening to the soft tissues as well. And then we're just going to add a couple of muscle resistive tests in there as well. So first one we're going to do is bring the hip up, and we're going to go into hip flexion. Okay, so we're seeing if there's any restriction in terms of the back of the hip of the buttock area, or even into the front as well. Because it's a lateral knee pain condition, we're probably not going to get any pain provoked in this area at this stage. Okay, so it is just specifically looking at the hip. Okay, so we've gone into flexion. Now we're going to go into the rotations. So the first one we're going to go through is just internal rotation of the hip. So we want to see how much range. So obviously I start to feel restriction there. Jenna, are you feeling that there? Whereabouts are you feeling that? Okay, so she's feeling it out here. So it's really important internal rotation in terms of where they do feel it, because there are a couple of places where it can be quite restrictive. Some clients might feel it deep in here, okay, more into the groin, which sometimes can be the hip flexor coming down here, sometimes can be the adductor muscles. If they're feeling it more out in the lateral part of the hip itself, then obviously the wonderful TFL, which is obviously a pretty important muscle when we're talking about ITB. And sometimes they might also feel it just deep in the external rotators as well. So it's important to note whereabouts they feel it and how much range of movement they've got. So, you know, for most people, about 45 degrees is the average. Now, that's internal. Now we're going to take it into external. So Jenna's got a lot more external rotation than she has internal rotation, but that's not necessarily uncommon. So when I'm doing that, are you feeling any restriction anywhere there, Jenna? No? Pretty good? Okay. All right, so that's internal, external rotation. We've got flexion. Now we're just going to go into abduction. So I'm going to take this leg here and just stabilise, so holding it so it doesn't move. And then I'm going to walk this leg out. So the idea is that we're testing whether or not, one, any pain in the joint as we move out this way, and two, what the length is on our adductor muscles. So just tell me when you start to feel a stretch, Jenna. About there. Okay, and that's reasonable range of movement once again. So with some of your more flexible clients, you might feel that they're way out here. Okay, we'll get you to spin over onto the front for us now. Now, because we've already done the Thomas test, there's a fair chance that you've already assessed what sort of flexibility they have in hip extension, but this is also another opportunity to assess that. So in doing so, what you're going to do is just bend the knee up. Now lift up the leg, put your hand underneath the top of the knee itself, okay? Come and bring your hand over the back, over their sacroiliac area if you like, and then you're just going to lift up from there and see how much range of movement they've got there, and also whether or not there's any pain on those as well. How's that there, Jenna? Pretty good. And as we noticed before, when we did Jenna's Thomas test, she was really quite flexible. Okay. All right, so that we've done that, now we can just quickly do some muscle resistive tests. And while we're in this position, we might just do the hip extension muscle test. 3 parts to this test. The first part is getting our clients just to lift their leg up and just holding it there, okay? So that's part number 1, is that they've got the ability to do that. So obviously their glutes need to contract to hold that. Second part is whether or not they can push up into our hand. Okay, good. And the third part is whether or not they can resist us as we push down, okay? Which is just a little bit more challenging. Well done, Jenna. We'll get you to spin onto your back for us now. So obviously that's a pretty important part for the runners, because if they've got weak glute heels and they're asking their hamstrings or their lower back to try and stabilise that, then that's when they can come in and have issues related to their hamstring and other areas and other injuries. So pretty important test, especially when we're talking about runners. All right, so now the next part here is we're going to do some muscle resistive tests for hip flexion. So just bringing the hip up into about 90 degrees, just shy of 90 degrees, just a slight bit of external rotation. Now just hold that there for me, Jenna. Now with any muscle resistive test, it's important that you control this. So what you say to your clients is, I'm going to push this, I want you to resist against me, okay? Now what that does is give you the ability to control the contraction, okay? Because if your clients are in control of it, they may want to just push straight back as hard as they can. We don't want that. We want to slowly build that contraction and see what sort of strength they've got, and whether or not it provokes it at the start of it or at the end of that contraction. All right, so just holding that there. I'm going to push, Jenna, and I want you to try and stop me from pushing you. And just slowly increase it. And if you like, you can use a count of 5. So just slowly to yourself saying 1, 2, 3, 4, 5, and slowly increasing that contraction as you go. Now, same again, obviously we're going to be doing internal rotation. But in order to do that, we need to take our clients into external rotation. Once again, I'm going to push in this way, Jenna, and I want you to try and stop me from pushing you in. So you need to stabilise the knee and also the ankle. Good, terrific, okay, no problems. And we're going to take it into, now this is resisted external rotation, but we're taking our client into internal rotation. Now once again, I'm going to do the same, stabilise the knee. I'm just going to push in towards myself. And great. No pain on that? No. Good. We shouldn't have thought so. All right. Now we're going to do abduction. So the idea here is same again. Just take the client out probably into about 10 to 20 degrees abduction. And once again, you can use your body weight here if you like. You may want to stabilise this leg here, because as they push in, sometimes they might push out from that leg as well. So once again, Jenna, I'm just going to push in from here, and I want you to try and stop me from pushing you. Good, and relax. And now while we're here, we can also do some resisted adduction, just to make sure that there's obviously no involvement in relation to the adductor muscles obviously being tight and being a contributor. So they certainly, once again, can draw on the pelvis and change some of the dynamics of the pelvis. So just place your hands almost crossed over, just above the medial malleolus. And once again, what I'm going to do, Jenna, is I'm going to push out. I want you to try and stop me from pushing out. And any pain on that? All good, terrific, fantastic. All right. And that concludes our hip range of movement. Okay, now we're going to do some treatment now. The first part we're doing is obviously we're looking at this ITB flexibility, and as I've obviously gone on and on about it, we're obviously going to address the gluteal fascia. Now, for the actual ITB itself, I don't myself do any work to it. If there's anything that I do to, it would be vacuum cupping. So for those of you that are familiar with vacuum cupping, especially Dave Sheehan's complementary health seminars, if you haven't done his workshops, by all means do, which is absolutely perfect for this condition. So, and would be a prerequisite for it as well. So I'm going to show you some of the hands-on soft tissue techniques that you can do in conjunction with vacuum cupping as well. So we've got Jenna draped here. Obviously, we use 2 towels. We're tucked in the top to the lower part of the brief, and then another towel that wraps around. So that just gives our clients the utmost privacy for this situation. As you can see here, this area here, this is our greater trochanter. So this is where a lot of the fascia from different areas are coming in, blending in and around that area. So this is a focal point that we're going to work off from. And we can also use the Obes test to give us a bit of an idea of whether or not we've made a change as well. So what we can do is that we can test pre, and then we can test post after doing these techniques. Now, as I said, you do this in conjunction with the soft tissue techniques that I'm doing now, and then you could follow it up or with the vacuum cupping, or vice versa. Please yourself, you can do it either way, but makes a massive difference in terms of trying the tension on this particular area. Now, I'm going to be using a bit of cream here, which is some MyoPro. Which has been specifically sort of designed for the vacuum cupping, but I've been using it for some soft tissue work as well, and it's absolutely fantastic stuff. It's got arnica and a whole range of other stuff in it. It's got just the right sort of medium for doing this sort of release work. Now, you don't need a great deal of this for this particular type of technique, which is great, so it goes a long way. So I'm just going to put just a small coating on here. And you'll need to test your client's skin moisture component, because some people naturally have oily skin. So sometimes you don't necessarily need a lot of lubrication. Sometimes you don't need any at all. The important part about when you're doing your myofascial work is that you don't put too much on, because if you put too much on, then you can't engage the tissue, and therefore you're starting to push in to engage the tissue, and you miss the medium of what you're looking for. So it's really important that less is better in this stage, and then you can always add a little bit more if you need to. Okay, so I'm just going to do this really statically to begin with. I'm not going to put any movement or anything to it. And I'm using, as I said before, the greater trochanter as my starting point. So what I'm going to come in, just using the very fleshy part of your forearm, I'm just going to come below the greater trochanter itself, and what I'm going to do is I'm going to drag the tissue up and over and almost on top of the greater trochanter itself. Now, keep in mind, if you've got a client with a trochanteric bursitis, this is not going to be pleasant. So it would be a contraindication to it. But because we're talking about ITB, lateral knee pain, our clients haven't got that. Okay, now that I've engaged the tissue, it's actually quite simple. From here, you just apply tension and you're going to be working up. In this sort of situation, we're going to be working up and sort of anteriorly, just at the back of the TFL muscle itself. How's that pressure there, Jenna? Not too much. Now, this is not penetrating. We're not looking at trying to engage trigger points. It is purely a myofascial release technique. And like all myofascial tension techniques, we let the body do its work. Okay, so don't try and push through this technique. Just let the body slowly release as we do it. And it will take some time on people who are really tight. So don't rush it. Just let the body do its work. Okay, and the beauty of this technique is that you can come along and just change the direction on where you're applying your muscle tension technique. So same again, but this time I'm just going a little bit more posterior and probably picking up a little bit more of the back edge, that gluteus medius component. Now, the adjunct to this is that once you've established this statically, what you can do is you can introduce some movement into this as well. Now, you're going to do these sort of techniques with clients that are used to you moving and working on them. If it's the first time your client's been in to see you, then I wouldn't necessarily introduce this straight away. And it also depends on their sensitivity and irritability as well. So pretty simple, depending on the person. If you've got a height adjustable table, then you can drop it right down and actually place the limb in between your knees and then work off that. Or you can hold it here like so, and you can work through the range of movement. So now what we're going to do is I'm bringing the hip up to about 90 degrees. Same situation again, applying the load, okay, engage the tissue, and then what we can do is just slowly walk out into some extension, okay, and then dropping the knee down into adduction, extension, adduction, extension. And once again, letting the body do the work. Now, with this particular type of technique, you can once again just slowly work through all the fascia of the hip. Now, we can place the knee and the hip into a little bit of hip flexion, and now we can come to the back part of the gluteal, and what you're going to be doing is working off, but this time back down through more the gluteal fascia of the maximus, but not penetrating into the external rotators at all. So this should be a very superficial sweep, not using your elbow at all. Okay, terrific. So that's our myofascial tension technique. Okay, now that we've done our myofascial work for the Obes, obviously, as I said before, it's really important that you test pre and post to see that you've made a change. Now we can direct a little bit more time towards maybe the trigger point therapy related to the hip. Now, once again, we've got our glute max, we've got our glute minimus and our glute medius muscle. So really it's more about placement of where the trigger points are. Now, with any trigger point therapy work that I do, it is, once again, really important that you actually massage the length of the muscle first. So the sequence will run like this. If we're looking at just massaging the gluteus medius muscle, okay, then what we're going to do is that we're going to massage the bulk of the muscle, okay, so which will be a very broad, long sweep, okay. Now, I don't mind if you work longitudinally, or you work transversely, or you work obliquely. Maybe a combination of all of those. Once you do that, you will then get a fairly good idea of where the irritability is in relation to the muscle itself. Now, for the trigger points in our glute medius muscle, our iliac crest is the landmark that we're going to be looking at, because essentially it is where the trigger points lie for the glute medius muscle. So if you can find your iliac crest, the top of it, okay, which is way up here, roll down off it into the fleshy part underneath the iliac crest. It is there where you'll find the 3 trigger points for the glute medius muscle. Now they lie, you've got an anterior, more one that's sort of in the central portion, and then obviously a posterior one. And they all refer in different areas. So the idea is that you would do your broad searching strokes, okay? Give the client plenty of time to accept your pressure. Understand this is the areas that you're going to work with. And then you can do what I class as your treatment strokes, which are basically going to be your short, specific strokes to the trigger points. Now you need to obviously communicate with your clients in terms of their pain thresholds. This is all underpinning knowledge that you probably should already know. So if we're talking with Jenna, obviously 0 out of 10 are our pain thresholds. 0 is no pain. 10 is the worst pain that they've experienced. We want to be at a 5 to 6. I haven't treated Gemma before, so I've not had the pleasure. So it's important that she understands that I'm not here to completely overwhelm her with pain. So it's really important that we're just within those thresholds and that I'm working through the tissue. Okay, so there's the most sensitive spot. So on a scale of 0 to 10, about a 5 or 6. And this pain may or may not refer. Obviously some clients it's obviously local, but the whole point of treating the trigger points is that obviously it drags on the capabilities of the muscle itself. So obviously deactivating it restores better function to the muscle. And with ITB, it's not always that people will have fatigue straight away in their gluteal muscles. It might be when they're about 3 or 4 Ks into the run. Okay, so gluteus medius muscles around the top of the iliac crest. If we come to the front, here's our greater trochanter. We roll off our glute medius muscle, then we sink into our glute minimus muscle, okay, which is a deeper portion but a smaller muscle. So we've got anterior and a posterior fibre here. They come up this way, almost like a bit of an L shape if you like. So once again, we have trigger points in the anterior fibres and we have trigger points in the posterior fibres as well. So it's those fibres that we're looking at. So once again, what we can do is come in with broad stroking. This time we're sinking in a little bit deeper. Just opening up our stance, bending our knees and getting our weight transference through there. Once again, keeping in mind our clients' comfortability. Okay, so now with some of your clients, especially with some of the athletes I've worked with and some of the athletes that you guys work with, you may need to use the forearm. So which means that you'll be dropping in, their muscle mass may be bigger, so therefore your fingers will not be able to give you the strength that you need to get into that tissue. So if that's the case, just dropping down and sinking into that tissue. Now, I probably don't need to sink too deep here with Gemma because she's obviously got a huge amount of muscle mass in this area. So we're just stripping through those areas again. Now, once again, glute minimus muscle is really, it's a different muscle in terms of referral from our glute medius because this is our pseudosciatic muscle. Okay, so the anterior fibres will refer down the back of the leg and even to the top of the calf. Sorry, the posterior fibres, and the anterior fibres will refer down the lateral part of the leg. Okay, which sometimes does actually mimic our ITB pain, which is actually really quite important. So once again, we can come in and strip the posterior fibres. May or may not get any referral from there. Okay, now that we've addressed the gluteal fascia, what we're going to need to do now is obviously looking at our vastus lateralis muscle and the TFL muscle. Once again, really important muscles. Obviously the TFL muscle is important because it blends in with our ITB, so obviously it has that anatomical relationship. The vastus lateralis muscle, obviously we have the ITB overlying it. It can also create lateral knee pain as well, but it's a large muscle and is very much involved in fascial restriction along these areas as well. So if your ITB is being pulled very tight due to the gluteal fascia, then sometimes you're going to get areas where they will bind down onto the vastus lateralis. Now, you can do a little bit of myofascial work here, which I'll show you, but once again, this will be picked up when you're doing your vacuum cupping stuff as well, so which is brilliant for this. So try and use both of these modalities if you can when you're doing this. Okay, so let's just do TFL first. Not a hard muscle to work on, because essentially you'll find it's almost just in that anterolateral part of the hip. So if we bend the knee up and then just adduct, okay, you'll see there, if you can pick it up with the shadows or not, but this basically, this piece of muscle here, that is your TFL. So that will come down and blend into here. And obviously also the trigger point for it is in the upper portion of it, which you can feel on Jenna at all, the lovely sensitive young lady that she is. So the pain will refer down into the lateral part of the leg. So what we can do from here is, as I'm saying, we're using a little bit of hip flexion, which takes the tension off a little bit, and then we can just adduct, and we can use just a really broad, soft fist to run down sort of myofascially and then up onto the TFL itself, okay? So it's long, broad stroking once again. And this particular type of technique is not really myofascial. This is obviously more of a soft tissue type technique in regards to just working through not only the fascia but also the muscle itself. And at the same time, we can pick up the trigger point, which is in the upper portion, which we can feel there. She's getting that slight twitch response. So if you like, you can come in with thumb, it's not too penetrating, or you can use a broad fist. And obviously any opportunity to save our thumbs works well. So just working through that and dropping the knee into adduction. Just opens up that whole area there. Obviously we're encouraging to lengthen that area. Now, vastus lateralis, as I mentioned before, vast muscle, obviously because it's large, and we're just looking at trying to offload the relationship here, if you like, of the ITB. Now once again, it's a broad contact, and just engaging the tissue here. Okay, now I'm not working on the ITB, I'm working off the ITB itself and along that lateral edge of the vastus lateralis. Okay, and this is more of a myofascial tension technique. Once again, I'll re-engage this one here. And the penetration is not down into the muscle, but very much along the length of the fascia. How are we going here, Jenna, all right?
Yeah.
So you will find in some of your clients who do come and see you for ITB syndrome that there will be real sensitivity right along this area, which essentially is where the trigger points are as well. For vastus lateralis, you've literally got 4 clumped in this area here. You've got another 3 here at the top, another 1 directly almost underneath, and then you have another 1 just here below the greater trochanter. So you've got quite a number of trigger points to address there, and you can strip through those just using longitudinal gliding and picking up 2 of the posterior ones and 2 of the anterior ones through there. Once again, they'll be referring in and around the knee. The 3 will be basically all clumped together here as well, so you can address them all at once, and they're all fairly sensitive through there as well. If they're too penetrating, broaden your stroke a bit more. You're going to pick up the greater trochanter trigger point down through here. Once again, coming along once again with broad stroking. Terrific. Okay, and then there's one more just at the back edge of this as well. So, vastus lateralis, the TFL muscle, gluteal fascia, focus points in offloading the tension onto the ITB itself. We can also do some short mini myofascial tension techniques over the top of the ITB along the length of it, just trying to free it up from the vastus lateralis along the length as well. Coupled with your vacuum cupping, absolutely imperative to offloading all these structures. But keep in mind that the larger picture that we'd also be doing would be addressing any restrictions, if there were, to our hip flexors, to our hamstrings, to our prone, to our quadriceps through here as well, because all of those have a direct effect on the balance of the actual pelvis itself.